So shall I share the screen?
Yes, sir, please.
So is it visible now?
Yes, sir.
So shall I start?
Yes, sir, please, sir. So the students are in, sir.
Just a minute. Okay, so good evening, everyone. I am Dr. Nitin Ghonge from Apollo Hospital, Delhi. So I will talk about radiology in clinical nephrology. And as I was told, this is mainly DNB nephrology students. So I will mainly focus on the basic aspects about how to deal with radiology investigations in day-to-day clinical practice of nephrology. And it is important for the nephrology students to understand the very basics of imaging investigations, the radiology in day-to-day practice, and then apart from the very basic concept, they should be able to interpret few basic things, but at the same time they should be able to know the potentials, the possibilities where radiologists can help them in a better way for a particular clinical problem. So they need to be aware about those advanced applications as well in the same time, so that they can advise investigation accordingly for better answers and more investigation in specific clinical settings. So as you all know, the clinical settings range from urinary calculus disease to calculus congenital or developmental lesions of kidney, infective or inflammatory conditions related to the kidneys, pre and post treatment investigations, imaging of renal tumor, renovascular hypertension and other vascular lesions, pre and post transplant evaluation or other miscellaneous conditions. So the most important basic investigation is an abdominal radiograph. So it is important for the nephrologist to at least make an basic interpretation about the abdominal radiograph. As we can see, the radiograph covers the abdominal part right from the level of diaphragm up to the pelvic cavity, and this is the region of the kidney. So we can see the renal shadow on both sides, which should be at least 3 vertebral body in thickness. So the normal length, long axis dimension of the kidney covers a span of 3.5 vertebral bodies, as we can see here. So this is how we can judge that kidney is normal in dimensions, even on the plain radiograph. But it is important to understand that only in patients who have optimal fat in the retroperitoneum that we will be able to see the shadow of the kidney. Otherwise, we will not be able to localize the kidney on a plain radiograph. So here we need to look at the renal area on both sides for any abnormal opacity, any abnormal density or presence of calculus or air, and trace the region of ureter on both sides along the level of transverse process, because this is the area of ureter, and which at the level of L5 S1 it flares out laterally and overlies the sacroiliac region, and then again turns medially to join the VU junction. So it is important to look at all this area of the ureter and the urinary bladder. For nephrologists, it is very important to understand the basic assessment of chest radiograph because of the common complications related to renal problems. So it is important to look at the apical region on both sides, the upper zones, the mid zones, the lower zones. And this is how the normal vessels should look like. They should be prominently seen in the inner 2/3, and there should be paucity in the outer 1/3 of the lung fields on both sides. So this is the normal appearance. This is how the renal hilum should look the pulmonary hilum should look like on both sides. This is a normal radiograph, and it is important to carefully look at the margin of the heart, which should be normally seen, and this dimension should not be more than uh, uh, 1/3 on of the total dimension of this inner to inner means cardiac index. Once you measure this distance, this should not be more than half of this distance. So this is a rough estimate of absence of cardiomegaly. So this is important to have a basic evaluation on radiograph chest. So as I mentioned, this is abdominal radiograph. The right kidney seems to be all right. The left kidney shows a presence. This is the outline of the left kidney, and here you can see the presence of calculus in the lower polar region, and then the ureteric region and the bladder is all right. So why CT is important? Because CT helps in exact localization of the stone, and exact attenuation values can be assessed on CT, and accordingly, once we can see the attenuation value, we can in a better position to understand whether the what is the density of the calculus and whether what is should be the expected treatment option based on its density and the location. So this is important to advise CT for these patients. So then secondarily, how likely the stone is likely to pass of its own depends upon the degree of inflammation, the size of the stone, and the degree of inflammation in the adjoining ureteric wall will determine whether it is likely to be impacted or it will pass of its own without any surgical intervention. So dual energy CT is an advancement which should be known to everyone because it helps in estimating the composition analysis of the stone is possible, and therefore the treatment can be accordingly decided based on different energies. We can decide whether it is an oxalate stone or a calcium stone. So accordingly, the stone composition analysis is possible with dual energy CT. For a nephrologist, it is important to understand the basic concepts of IVP or CT urography. Now, conventional IVP or IV urography is not commonly done, but the concept should be very clearly understood because it applies to CT urography also. So, on a plain radiograph, we can see the margins of the kidney on both sides, but as soon as the contrast is given, after the first pass, the contrast from the heart reaches the renal artery, extends into the renal parenchyma, and initially we will be only able to see the outline of the kidney, what is called as the nephrographic phase. And after 5 minutes or so, then the contrast will be excreted into the chelation system, the pelvis, and the ureter will be opacified. So this phase is called the pylographic phase. So depending on the exact timing, the contrast will be seen in the renal parenchyma or in the renal pelvis and the ureter, and finally into the urinary bladder. So here is an example of IVP film where we can see the alteration in the altered axis of the chelation system on right side. Similarly, on the left side, more important is the widening of the kidneys on both sides. So there is something space occupying lesion in this location in the rectoperitoneum with altered course of the ureter because of the large rectoperitoneal mass, lymph nodal mass. Another possibility which lesion which can do something like this is presence of aortic aneurysm, which can also cause widening of the kidneys and can be evident on IVP like a similar manner. This is another example where rather than widening of the kidney, widening of the ureters are closely located. They are medially deviated. So this is the normal place, but here it is medially deviated. They should follow the transverse process, but in the lower part, they are quite medial and very closely located at the level of sacrum, and then again translaterally. So this is called the maiden waist sign. Maiden waist sign is seen in rectoperitoneal fibrosis. So this is what I was telling on IUP. The same applies to CT urography. The corticomedullary phase. It is important to understand this phases in CT. As soon as the contrast is given, this is the dot which is seen. The contrast is seen in the renal artery segmental branch, and after 30 to 40 seconds, we can see the corticomedullary phase. The cortex is seen as bright structure. The medulla is little dark, and these dot-like areas are the segmental branches of the renal artery. In a nephrographic phase, the corticomedullary differentiation is little attenuated, but still the cortex is bright as compared to the medulla. So this is a nephrographic phase at around 2 to 5 minutes. After between 5 to 15 minutes, you will see the contrast is excreted into the chelation system, and the density is now seen in the pelvic chelation system, the renal pelvis. So this is a pylographic phase. So in a conventional IEP, we will not be able to differentiate cortex and medulla. Only on CT we will be able to differentiate cortex and medulla. So unlike IVP, on CT, on conventional IEP, there will be only two basic phases, nephrographic phase and pylographic phase. On CT, there will be a third phase called corticomedullary phase, which is the earliest phase and will only be seen on CT urography, not on conventional urography. So this is how the CT urography image will be seen from top to bottom. You can see this. If a contrast is given and conventional radiography is acquired, this is how it will be seen. The same thing can be regenerated with CT urography, and we can see the complete length of the ureter, the pelvic chelation system up to the view junction on the CT urography as well. CT, there are certain modifications also, like you cannot, CT imparts radiation. So it is important to, you cannot take, unlike IVP, you cannot repeatedly acquire CT phases because there is increased radiation. So this is a modification where you have given contrast in two different phases. The first phase is given 5 to 10 minutes before, which is now already in the pelvic chelation system and the ureter on both sides, while another contrast is given, another phase of bolus of contrast is given 5 to 10 minutes later, which is still in the renal parenchyma, and therefore this aorta and renal arteries are seen. So this allows, this split bolus method allows simultaneous visualization of renal artery on both sides, the renal outline of the parenchyma on both sides, the chelation system on both sides, the ureter as well as the urinary bladder in a single acquisition, which reduces the radiation significantly. Now look at the IVP image, look at the filling defects. This is the normal C-shaped calyx, which should always be seen like this. This is the filling defect, will be seen as a, maybe because of the stone, as we can see the stone here with the focal shadowing here. There is Doppler is a very sensitive to pick up stones because it elicits artifacts like this. So Doppler is a better way of picking up small chelation stones which are not optimally giving any shadow. It is important to realize that stones are quite over-reported on ultrasound if the correct technique or care is not taken during by performing ultrasound. It is important to avoid mistaking the renal artery turns or renal artery interfaces as calculus, which is commonly seen in routine practice. It is important to look at this bright area with discrete shadowing or artifactual aliasing to call a stone as a true stone, and it should not be the false localization or the false diagnosis of a stone, which is often seen because of simply looking at the ecogenic area in the renal hilum doesn't qualify as stone unless and until there is a Doppler signal or unless and until there is a discrete shadowing. Only then it should be labeled as a stone. Otherwise, it may be a renal artery ecogenic neural foci. Filling defect in the urinary bladder may be because of TCC, as we can see stippled surface, and then this is complete deformity of the urinary bladder. This is conventional IEP, and now this is a film acquired at 5 minutes, so you can see the outline of the kidney on left side, but contrast is also seen in the pelvis and the ureter on left side, so this is normal. But at 5 minutes, the right kidney is not showing any contrast in the ureter or the pelvis, only the renal outline is seen. So after 5 minutes, this is the scene, and after again 15 minutes, this remains like this, while this is showing continuous excretion of contrast. So this is called persistent nephrogram sign. Persistent nephrogram sign. This is suggestive of high-grade obstruction of the renal pelvis on right side. This dense persistent nephrogram is an important sign. Here you will not be able to see the contrast excreting into the renal pelvis and the ureter, and because of the dense persistent nephrogram. The ureter will always be seen like this on what we see on the right side. At some area it is narrow, at some area it is normal. This is not narrowing, this is only peristalsis. So this is normal appearance. If the ureter is seen as like this, equal in caliber throughout its length, this is not normal because this is called standing column of ureter and often raise possibility of obstruction, calculus or mass at this location in the view junction. Ureteric jet can be seen on ultrasound like this, which also helps in ruling out the calculus in the view junction or any ureteric obstruction. It is important to carefully look at the location and the axis of the pelvic ileal system. This is the normal kidney, normal pelvic ileal system on left side, but here it is completely depressed, and this is what you call as a drooping lily sign because of the double moiety ureter. Double moiety ureter non-functioning, it is causing extensive compression on the lower moiety which is functioning. So this drooping lily sign is an important observation once you see this kind of appearance. So this is important to localize the exact view junction, exact site of view junction on CT urography. So this is what another example where we can see the focal filling defect at the view junction because of the cobra head sign. Cobra head sign is because of the ureterocele at the view junction, which can be seen as a rounded filling defect on the right side or the left side. Then again, this is an example I showed in the previous slide. At this location, the ureters are very close to each other, and this is happening at the level of L4, L5 level. This is called median waist sign or medial deviation of the ureter because of the retroperitoneal fibrosis at this level. If this is happening only on right side, then it is important to consider the possibility of retrocaval ureter also, which is seen only on right side and not on the left side. If it is seen on both sides, it is because of the medial deviation of ureter because of fibrosis in the retroperitoneum. This is what I was telling. This is only left side is normal. Only medial deviation is seen on the right side, which is also dilated. So here you can see this is the aorta, this is IVC, and the ureter should not be posterior to the IVC. Here it is posterior, so this is a retrocaval ureter. Now, very important on IEP, this is the Chelation Anatomy. The C shape is a normal appearance, and then so this C shape is a normal appearance with this is the minor papilla and this is the major minor calyx. This is the major calyx and this is the renal pelvis, the ureter. So here this C-shaped appearance with the indentation of the medullary pyramid is a normal appearance. But here what you can see in this image, the C shape is lost and there are multiple tiny punctate foci seen in the region of medullary pyramid and the minor calyx in this image. So this is called dot dot appearance or paint brush appearance or bucket of flower appearance, as we can see here in this image. This is characteristic of medullary sponge kidney, which can also be diagnosed on urography, conventional or as well as CT urography. This is another IVP image. The C shape of the normal calyx is completely lost. They are all elongated calyces. Elongated calyces. The shape of the kidney is enlarged. The renal size is enlarged more than 3 centimeters height, vertebral height, and then abnormally stretched, elongated chelation system on both sides. This is because of the spider leg appearance of medullary polycystic kidney disease. Polycystic kidney disease. So this is CT image. You can see the normal appearance, the medulla, the cortex on the right side, the IEP, the IVC is all right, the aorta is all right, the left renal vein is normal, but here you can see the abscess in the peripheral part, abnormal edema in the parenchyma, and then this is the renal vein where there is focal filling defect. So this is renal venous thrombosis because of the renal abscess on the left side. How to diagnose tuberculosis? It is important to look at the in late stage end stage kidney disease. It is a putty kidney which is small, shrunken and calcific as seen here. But in an early phase, it can be seen as infundibular stricture with focal caliectasis or caliaceal dilatation, which is cut off from the rest of the kidney and can progress to renal parenchymal cavitation also to suspect tuberculosis. So this is another example where we can see the tubercular kidney with focal parenchymal cavitation and the inflammatory changes are extending outside, and gradually even involving the hepatic surface. How to differentiate renal tuberculosis from renal papillary necrosis, where papillary necrosis is a very important diagnosis to be considered in nephrology practice, particularly in diabetic patients or with patients who are on long-term NSAID, sickle cell disease, analgesic, diabetes, or infections. So the density of the contrast remains same. In tuberculosis, the density of the contrast reduces because it causes functional derangement as well. But in renal papillary necrosis, the density of contrast remains the same, but there is abnormal shape of the chelation assembly. The C shape is completely lost, and there can be different sundry shapes, sundry appearances can be seen as shown these images to suspect renal papillary necrosis. Then when it comes to CT MRI evaluation of complex cyst versus cystic neoplasm, this is how you can see the dark lesion, hypodense lesion on CT, right kidney. Margins are sharp and angular interface. So this is benign. If you see the margins are ill-defined, rounded, not angular. So this rounded margin suggests malignancy, sharp angular margin suggests benign complex cyst. Similarly, you can see multiple lesions on both sides, and then this is the RCC on the right side, which is extending into the IVC. Now, IVC can have bland thrombus or tumor thrombus. If the IVC is not enlarged and the thrombus is dark, then it is usually a benign bland thrombus. But here you can see the IVC is grossly dilated and the thrombus is also enhancing because of the tumor thrombosis. So this helps in deciding the exact stage and the surgical outcome and surgical approach. How to differentiate PCC from RCC from in a renal tumor? Look at the shape of the lesion. This is a ball morphology of a right renal tumor, while this is a bean morphology. So what is the difference in ball morphology? The shape of the kidney is distorted because of the pressure effect of the mass. But in bean morphology, the reniform shape is always preserved despite the size of the lesion. So when we have the bean morphology, suspect TCC. When we have a ball morphology, whether it is exophytic or endophytic, suspect RCC. CT can also help in predicting the histological variety of the tumor. Like this is a CT urography. You can see the right renal artery. The large cyst is there, but there is a focal exophytic lesion with recruitment of extrarenal vascularity here because the lesion is quite vascular. So always we need to look at the degree of enhancement of the lesion renal tumor as compared to the aortic enhancement. So this is aorta, which is bright, and this is the degree of enhancement. So the comparison, the ratio of this enhancement versus aortic enhancement, if it is above the cutoff of 0.25, it is likely to be clear cell tumor. If it is hypoenhancing, like this is a tumor, this is a tumor, look at this enhancement and compare it with the aortic enhancement. So the ratio is significantly less than 0.25. So this is likely to be non-clear cell tumor. So this is how we can even predict the histological variety of a renal tumor on a CT contrast study. CT में there are different. It is important as a nephrologist, you should know that there is in previous times there used to be 5 mm scans or 3 mm scans or 10 mm scans, so clinician has to convey. But now there is nothing like that. It is all volume scanning. Now we are in an era of multi-detector CT, where there is volume acquisition. Once we acquire the volume, it depends on the radiologist and the technician to cut the volume in either 10 mm or 5 mm or 1 mm or less than 1 mm sections, depending on the clinical requirement. But there is a lot of post-processing options which are possible with volume scanning. So MIP is a maximum intensity projection, and VRT is a volume rendering image. So these are different forms of post-processing protocols which helps in looking at the complex venous anatomy or a small intrarenal arteries. This is the plane for the right kidney where we can see the complete course of right renal artery. This is the plane for left renal artery where we can see the complete course of left renal artery into the renal hilum. This is a curved plane or a curved MPR where we can see the renal arteries on both sides in a single image. So we can process the volume data according to a particular line, which can be straight or which can be curvilinear. Now, contrast can lead to contrast-induced nephropathy or CT contrast, iodinated contrast can lead to contrast-induced nephropathy. MRI contrast can lead to nephrogenic systemic fibrosis. So it is important to calculate the eGFR, and accordingly only the contrast can be given. If the eGFR is more than 60, there is no risk or negligible risk. The eGFR is less than 30, then there is high risk of contrast-induced nephropathy with CT contrast and NSF with gadolinium-based agents in MRI. So therefore, it is important to calculate eGFR, not only serum creatinine, before these patients are subjected to contrast studies. So it is important now to understand if the patient cannot be given any contrast, IV contrast, because they are excreted through the kidneys and the KFT is not normal, serum creatinine is elevated, as is a common setting in nephrology practice. So there is something called as contrast enhanced ultrasound, which you should know, because this can be used even with patients who have abnormal serum creatinine, because this is excreted through lungs. These are blood pool agents. They increase the number of interfaces in the vascular lumen and helps very useful in patients where KFT is deranged and you need to do a tissue perfusion study or assessment of a lesion. So image acquisition is possible with dedicated software, and it needs specific expertise, and specific contrast is required, which is contrast is required separate, which is contrast which is excreted through lungs. So therefore it is safe in patients with abnormal creatinine. Also needs specific machine, specific software, which is now increasingly being done in different centers, even in India, even in Delhi. And the indications include, intra-abdominal indications include focal lesions including liver and kidneys. Even the lesion in the spleen can be evaluated. Intracavitary used in urology and gynecology is also known. And there are very few contraindications. So this echocardiography also uses this contrast patients where IV contrast cannot be given. So these are the examples. Like this is a pre-contrast scan. This is how the liver and the right kidney is seen. This is the cortical phase. Again, you can see the parenchyma. Particularly the cortex is very bright in the cortical phase with a contrast, ultrasound contrast. And you can see the medullary phase where the medulla is also bright and the CM differentiation is poor. So here you can see the Bosniak category 2 lesion. Bosniak category 2 lesion, and here you can see there is focal lesion in the right kidney, and there is some degree of enhancement along the wall of this lesion seen with IV ultrasound contrast. Then again, RCC versus angiomyolipoma, you need to look at this enhancement which is happening in the peripheral part of the lesion, and therefore this suggests that this is likely to be an RCC because of the intense enhancement in the early phase of the contrast ultrasound study. The same contrast can be used in this is how it can be reciprocated on a patient. This patient had abnormal serum creatinine, IV contrast. It was difficult to give IV contrast, though it was later given for confirmation, and because the patient was on dialysis. So here is a focal lesion in the liver, which was quite little dark on CT. This is the normal arterial phase enhancement on CT, the same appearance on ultrasound, and in the venous phase itself it shows washout, which corresponds with the ultrasound image to suggest that this is a HCC in a cirrhotic liver. Another very useful application for nephrologists is a non-contrast enhanced MRI, where if the patient has abnormal creatinine, so ultrasound contrast can only be used in patients in lesions which are optimally seen on a non-contrast ultrasound and otherwise not. So for those patients where KFT is deranged and the lesion is not very nicely seen on ultrasound, whether it is plain or contrast, then non-contrast MR angiography is a very good option, where these are the images acquired without giving any contrast to the patient, because MRI, unlike CT, works on the principle of several complex physical principles, where flow itself can be assessed without need for any external contrast. These are the non-contrast MR angiography images, which can see the main renal artery, the aorta, and the renal arterial bifurcation, even in the segmental, subsegmental level, as we can see on both sides. It is important to understand that MRI tends to overestimate the degree of stenosis, as we can see here. Then stent evaluation is not possible with MRI, as we can see here. The stent, there is complete drop off. This doesn't mean that the contrast this is occluded. There is artificial darkening because of the stent. So MRI is not good for stent evaluation. MRI is not good for exact quantification because it tends to overestimate. So just skip few slides. So this is important to understand that for stent evaluation, the CT angiography is the best modality because it helps in looking at the contrast, and it helps in looking at the adjoining wall and the perivascular structures also. So CT angiography is a better modality for stent evaluation as compared to MRI, which tends to cause dropout in the region of the MRI, the region of stent. This is another example. Here you can see the focal narrowing in the distal part of the stent seen on the VRT image of CT. When we cut across the stent, we can see there is neointimal hyperplasia, which is causing in-stent stenosis. The CT angiography is a better modality to study the stent-related stenosis in the renal artery. When we talk about renal transplant, it needs imaging at different stages for donor evaluation, for recipient evaluation, for immediate post-transplant assessment, and for early and late post-transplant studies. For transplant recipient, to look at the iliac fossa region, to look at the space available for the transplant, to look at the tortuosity of the iliac arteries on both sides. So the basic surgical concepts are known to everyone. The CT is useful to decide the fitness to donate. Renal status should be evaluated, and the regional anatomy to decide the surgical approach. If it is open nephrectomy, open harvesting, then it is relatively easier. But with the laparoscopic donor nephrectomy, which is now increasingly being done, we need to be very clear about the regional anatomy to decide the exact surgical approach of the vessels and the non-vascular structures. Like this is the golden triangle, where the surgeon needs to place a clamp at this location to preserve the ureteric supply to this part of the ureter. So it is important to locate these vascular channels, to look at the anatomy of the renal vein, the renal artery on the left side, and this gonadal vessels and the lumbar vessels on either side to exactly decide the surgical clamping. This is important because if the vessel is less than 3 mm, then cautery will be sufficient, but otherwise more than 3 mm vessel will need a proper ligation. So imaging of a renal allograft is essentially done with ultrasound, Doppler and spectral Doppler as a first imaging investigation, and subsequently CT may be required. MRI is a very important tool, as I will mention subsequently, or at times DSA and nucleate scans are also required. Peri-transplant collections like seroma can be seen on CT and MR urography. And here is an example where we can see the distal ureter is anastomotic failure is there. Therefore, there is gross collection in the peritoneal cavity, and we can see the distal ureteric stent is floating freely in the peritoneal cavity. Urinoma, ureteric stricture can be seen as a narrowing with proximal dilatation. Urothelial edema can be seen on the CT urography image in a patient where we can see the transplant in the right iliac fossa. Then renal vein thrombosis is a very important diagnosis, which can be easily picked up on Doppler, and we can see this is the renal arterial Doppler should have high systolic flow and then should have a good forward flow in the diastole. But here in this patient, you can see that there is reversal of the flow in the diastole. This is an important observation, and it raises suspicion of the renal vein thrombosis, which is seen in this image, where artery is seen and the vein is not seen at all. Then anastomotic side aneurysm can be seen, can be confirmed with CT angiography, as we can see here. And this is an example of an anastomotic side pseudoaneurysm seen on Doppler, where we can see a large aneurysm at the site of anastomosis without using any contrast. This is a MR angiography image where we can see the neck of the aneurysm also, and we can see all the details of the aneurysm in relation to the renal vascular pedicle. In this example, where we can use non-contrast MR angiography in this patient without any use of contrast. So This is an example of a transplant kidney in the right iliac fossa. You can see the filling defect in the renal pelvis because of the fungal ball, which is highly echogenic and weakly shadowing. Doesn't cause any shadowing like a calculus. And then we can see the tuberculosis in a nephrostogram image where we can see the irregular margins, chelation defects, focal filling defects in a patient with fungal in a tubercular infection in a transplant kidney. Here, this is an example where we can see that squamous cell tumor, squamous cell carcinoma at the psychoureteric junction. The renal allograft is seen. So here, this is an kidneys should show this kind of hilum in a transplant kidney, but here it is a faceless kidney. There is no hilum seen in this transplant kidney, so it is important to suspect malignancy or lymphoma in such patients where the transplant kidney is showing obliteration of the renal hilum. Then small vessel ischemic process is important, which is basically a vasculitis, small vessel vasculitis or polyarteritis nodosa. The nephrographic image should show normal uniform enhancement of the cortex. Here it is multiple areas of dark attenuation are seen in the kidney on both sides and with or without abnormality in the renal vessel. So this is because of the small vessel vasculitis in a patient with PAN or polyarteritis nodosa. At times we can have aortic dissection, and here because of the long-standing dissection and the renal artery arising from the false lumen, you can see the ischemic nephropathy changes. The kidneys are small and shows abnormal enhancement on CT because of the deranged renal perfusion. This is another example where we can see that this is the normal enhancement of the kidney. This is the abnormal dark enhancement appearance, small size kidney because of the nephropathy and because of the distal thrombosis. Here we can see the right kidney normal, right renal artery is normal, but left kidney is completely occluded and needs to post ischemic nephropathy. Then we can see CT angiography images can nicely show the aorta and its relation with the renal artery, which is important from surgical point of view for some patients who have to undergo surgery for aortic aneurysm, as seen in this example. So here we can also see the aneurysm in the intrarenal segment in this patient, which also needs to be handled, addressed with the endovascular treatment. Aortoarteritis can be seen here in this example where narrowing, thickening of the wall can be seen. Multiple renal arteries can be seen on both sides, and because of the narrowing in the upper accessory branches, we can see the upper part of the kidney shows atrophy, lower part is all right. It is important to look at the long axis of the kidney, which is usually seen in the sagittal image. So in the sagittal image, you can see the actual long axis and not in the coronal view. Coronal is what we see from the front, sagittal is what we see from the side. So fibromuscular dysplasia can be seen as bleeding of the renal artery on both sides, which may be at times associated with the iliac artery as well as the SMA. So this is the fibromuscular dysplasia. In patients with pelvic junction obstruction, there can be presence of a crossing vessel which can lead to indentation of the over the pelvic ureteric junction. Now coming to more common entities in pulmonary, in day-to-day nephrology practice, pulmonary edema is very common, where we can have bat wing appearance like this, which can have wheel-like opacity along the lung fields, as we can see here. At times there can be rounded node lesions like this, which are fluid-filled areas because of the fluid in the fissure, the major fissure. So this is pulmonary edema on chest X-ray, pulmonary edema on HRCT. Then pneumocystis, zero vacuum or CMV infection. So pneumocystis should show small presence of small cystic foci, lower lobe involvement, and interstitial thickening, as we can see here in this patient with pneumocystis carinii infection, or also called as zero vacuum infection in HRCT. While these kind of subtle, small, peripheral areas of ground glass opacity or peripheral GGO is a hallmark of CMV pneumonitis, CMV infection. These infections are very commonly seen in post-transplant patients. So this is important for nephrologists to know and understand. Similarly, fungal and tubercular lesions are also common. So this is hallmark and classical appearance of tubercular bronchiolitis, where you can see multiple nodules, and those nodules are showing the appearance of tree in a bud. So tree in bud appearance is a hallmark of tubercular bronchiolitis. While if you see a lesion which is nodular, which may show central cavitation with surrounding area of halo. If you look at this area, there is this part where the lung is still not normal. So this is because of the perilesional hemorrhagic changes in a fungal infection. So this is important to understand. COVID-19 pneumonitis is now everyone knows, because they also shows peripheral ground-glass opacities which are quite confluent, and they show peripheral predisposition in early patients, early cases. But as the lesion becomes confluent, and they can have mosaic pattern, and as patients progress with increasing CT severity score, you can have this kind of picture where all opacities are confluent, and there are only few areas of sparing. Brain infarcts are at times seen in patients with renal disease. A fungal abscesses can also be seen, it is important to look for any focal lesion whenever you are looking at a brain scan. If this is the gray matter, this is the white matter, and if there is a large area of bright signal on T2 weighted images, always suspect a infective focus in the brain. If the abnormal area is predominantly seen along the posterior aspect, this is an important differential in a post-transplant setting, what is called as posterior reversible encephalopathy syndrome, or PRES, which helps in which is not actually infarct, but this is a unique pattern of vasogenic brain edema, and which is a completely reversible. So therefore, these are the diffusion weighted images which are hallmark of infarct. If you see restricted diffusion, any bright signal on diffusion image, it is a sign of infarct. If it is not affected, then it is likely to be a posterior reversible encephalopathy syndrome, or PRES. In renal transplant, they are usually late onset as compared to other settings associated with hypertension, and often has less brain edema. So as you are aware of the progression of chronic kidney disease, I will emphasize few important points. Just something called as functional MR studies. So now there are right now, renal biopsy is the standard of care, which can only confirm the degree of CKD. The closest non-invasive option is a Doppler assessment, which tells you the RI values. But RI has significant limitations, and you cannot exactly decide many things because of the significant overlap. So therefore, there is significant literature now coming up which talks about functional MR studies, which include bold MRI, diffusion-weighted MRI, diffusion tensor MRI, and arterial spin labeling MRI. So this is the basic concept. Whenever there is CKD, there is problem in the tissue oxygenation. There is this vicious cycle sets in loss of peritubular capillaries, which can be detected with MR renography. There is interstitial hypoxia, which can be detected with bold MRI. And then there is local inflammation and fibrosis, which can be detected with diffusion-weighted imaging or diffusion tensor imaging. So these are the bold MR images, which helps in the exact quantification of the oxygen levels at a particular site in the medulla, at a particular site in the cortex, and this is how it can be color coded to decide what is the degree of CKD. So I will not go into those details, but I will tell you, like, this is an example of a diffusion tensor MRI. This is also coming up in a big way, where this is a diffusion tensor MRI done at our hospital only. We can see the exact isometric orientation of the nephrons in the kidney, which can be seen and detected on MRI, the functional MRI or DTI image. So this suggests normal kidney because of the isometric appearance of the nephrons, and this is how it can be seen. This is an image from the literature. So the earliest changes in the orientation of the nephron suggest very early diagnosis of CKD, as we can see here in this article, where we can see the normal renal allograph shows absolute normal linear arrangement of the nephrons in the kidney, and with moderate dysfunction and with severe dysfunction, you can see the changes in the arrangement of the nephrons because of the diffusion tensor imaging, without giving any contrast to the patient. This is our non-contrast images, which helps in functional evaluation of the kidney and is likely to be much better tool as compared to RI for non-invasive evaluation of the renal transplant, and that too very early evaluation. This is what is called as multi-parametric functional MRI, where structural assessment is done on T1 and T2 images, then bold, T2 mapping, T1 mapping, diffusion weighted MRI, diffusion tensor MRI, and renography and phase contrast MRI. So these are all different tools. Few are associated with all are associated with specific aspect of the CKD progression. So just a few spotters. So this is, you can see the putty kidney on the right side, the normal kidney on the left side. Here you can see the renal abscess on the left side. Here there is a fluid level and the milk of calcium cyst on the right side, milk of calcium cyst on the right side. So again, here you can see the fusion of the lower pole because of the horseshoe kidney. This is another example where horseshoe kidney is associated with polycystic kidney disease. So this is the simultaneous presence of polycystic horseshoe kidney in the same patient. Then here we can see the abnormal shape of the bladder, the pear-shaped bladder, pear-shaped urinary bladder because of either lipomatosis or because of the trauma and hemoperitoneum. Here again we can see the pear-shaped urinary bladder because of the pelvic fibrolipomatosis. The shape of the bladder is completely deformed and it leads to back pressure changes. Bilateral renal hydronephrosis is seen. Then you can see this is another very important pseudomass. In patient with CKD, there are at times focal segmental hypertrophy of the spared areas, which can be confused for a pseudotumor. So this is important to carefully evaluate on Doppler as well as on MRI, and should not be, whenever there is a focal lesion which looks larger but is iso intense to the normal kidney on MRI signal intensity, then it should be, it may be focal segmental hypertrophy and not a malignancy in a CKD in an atrophic kidney. This is the normal right kidney with a normal renal hilum, but here the left-sided renal hilum is lost. This is because of the faceless kidney in a patient with lymphoma. Another differential will be transitional cell carcinoma. This is an important observation. The left renal vein is dilated lateral segment, but in the medial part between the SMA and the aorta, it is constricted because of the nutcracker phenomena, nutcracker syndrome, which is an often forgotten vascular cause of hematuria. This can lead to hematuria because of the increased localized pressure in this segment, which leads to transmission of pressure into the gonadal veins, and the patient can also have hematuria in this condition. Here we can see the median waist sign again, which we have discussed previously because of the retroperitoneal fibrosis, and this is the moth-eaten appearance of the nephrogram, the conventional nephrogram, because of the small vessel vasculitis, which can be seen like this on DSA image. This is the spotty striated nephrogram. Once you see a straight, the nephrogram should be uniform from top to bottom, like on all sides. But if it is a striated nephrogram on both sides, it is important to rule out acute pyelonephritis or distal obstruction or acute tubular necrosis in these patients. So, this is again chest radiograph showing fluffy opacities on both sides with loss of CP angles are poorly visualized. Diaphragmatic margins are poorly seen because of the pulmonary edema. So this is how it will be seen on HRCT image. And this bat wing appearance is particularly seen in patients who have renal origin, pulmonary edema because of the renal origin. Once you see multiple lesions on both sides, it is important to suspect METs or infection. If the lesions are variable size, like one lesion is small, one lesion is large, variable size lesions always suspect metastasis. If the lesions are similar size, it can be because of the infection, including tuberculosis. If the lesions are not seen on routine images, not seen on routine CT, MIB images is always better because they will be able to locate and diagnose even very small nodules as small as 2 to 3 mm. Now, small lesions, few lesions are large, few are small, few are large, few are small. So this is typically metastatic nodules, not infection. Again, IEP image, you can see normal appearance on left side, dense persistent nephrochem on right side, no excretion in the pelvic chelation system on right side, and you trace the ureter on both sides. And here we can see the ureteric calculus. So this calculus is causing the dense persistent nephrogram and no excretion of contrast into the ureter because of the high grade obstruction in this urography. Then again, this is the MR image, axial images, renal. On MRI, the vessels look dark because of the flow void. The normal vessels are dark as seen here. This is the normal right kidney, normal signal appearance on T2 weighted images. Why T2? Because the CSF is bright. CSF is bright. This is T2 weighted image. But on the left side, you can see striated appearance, very inflammation is seen. The signal is altered because of the left-sided pyelonephritis in this image. Similarly, another example, you can see the left kidney is normal on the CT image, and here we can see the focal areas of parenchymal cavitation because of the pyelonephritis, which was later found to be tubercular in this example. Here we can see the focal filling defect in the right renal pelvis, which is dilated. So focal filling defect is also seen on the CCT urography image, where white area is the excreted contrast. The dark area is the filling defect of the fungal ball. So this is a patient. Even fungal ball can be seen in transplant kidney also, and even in the native kidney also, as shown in this example. This is another example. Here we can see that this is a plain scan. Vascular calcification is seen, and this should not be confused for stones on ultrasound. So left kidney seems all right because the attenuation is all right. Only some surface irregularities there. Perinephric fat is all right. But here on the right side, there is gross deformity of the kidney. There is obstructive calculus in the renal pelvis, and then there are the renal outline is poorly defined. There are gross inflammatory changes, the presence of air because of the emphysematous pyelonephritis in this example where the renal pelvis is obstructed. These patients can at times also show xanthogranulomatous changes also, such obstructed kidneys where long-standing obstruction is there. So presence of air in a kidney, always suspect emphysematous pyelonephritis as shown here in this image. So to summarize, right from urinary stones to congenital developmental lesions, from infection to inflammation, renal tumor assessment, renovascular hypertension, evaluation of the stent, and pre and post transplant assessment, and miscellaneous other roles. It is important for the nephrologist to diagnose and look for few basic things to understand basic concepts about X-ray, CT, MRI. But at the same time, it is important to know the potential and the possibilities which radiology can offer. So therefore, accordingly, they can advise the investigation and they can ask for specific answers from their radiologist in their routine clinical practice. Thank you.
Thank you so much, sir. We can have some questions from the audience.
Yes, if there are any questions, so we can answer them. So there is a question, Doppler suggests of segmental involvement. RACT. Okay. So this is a very good question. Doppler is definitely the first line imaging investigation which suggested renal artery stenosis, but at a segmental level. So it is important to understand that MR angiography with or without contrast will always have a lower spatial resolution as compared to CT. So if you are suspecting stenosis or narrowing in the main renal artery, then MR angiography is good enough for main artery or the polar branches. But if you're suspecting narrowing in the segmental branch or an intrarenal segment, then CT angiography is always better in terms of degree of accurate diagnosis because of its higher spatial resolution. Only thing is it will add to radiation. That is the only concern. Otherwise, with a normal KFT value, CT angiography should be preferred. renal dysfunction is present, then which one to be done? If renal dysfunction is there, then definitely non-contrast MR angiography is a very good option. It will be the main renal artery and its major branches will be very clearly seen on non-contrast MR angiography without any contrast, without any risk of contrast-related problems. Only thing is if the patient at times the finer internal branches may not be very clearly seen, but in most of the cases the non-contrast MR angiography provides enough information in patients with renal dysfunction. So if KFT is normal, CT angiography. If KFT is not normal, then MR angiography. And if there are specific circumstances where ultrasound contrast is very useful, that everyone should understand that for focal lesions, so ultrasound contrast is also possible, but it is not done at all the places, so that is the main concern. Otherwise, non-contrast MR angiography is done at most of the places. So if there is any more questions?
Don't think so, sir. Any questions?
Okay, there is one more question. Can angiomyolipoma be diagnosed on USG? Yes, of course. Angiomyolipoma can be very well diagnosed on ultrasound also, though it is almost always clearly diagnosed on CT and MRI. But angiomyolipoma need to have small focal areas of vascular dilatation with macroscopic fat. Macroscopic fat is something which can be definitely seen on imaging, including ultrasound. So a large angiomyolipoma will always be diagnosed on ultrasound, but only those small angiomyolipomas may not be diagnosed on ultrasound where CT and MRI is required. But a fairly sized more than 2-3 centimeters of angiomyolipoma should always be diagnosed on ultrasound because fat has a discrete appearance on ultrasound also.
Thank you, sir. I think it was a very interesting session. Radiology is something they look forward to every time, sir.
Okay.
And hope, sir, we can share the video with the students.
Yes, yes. If there are any queries, any questions in future, you can forward them.
Surely, sir, surely.
Students can even call me if there is any particular query or any question related to radiology, understanding of radiology procedures or in a particular clinical scenario also. So
fine, sir. Thank you, sir. So nice of you. Surely I'll share your details, sir.
Okay, thank you.
Thank you again, sir. Thank you.